High blood pressure is also a relative contraindication to oral contraceptive use. Oral contraceptives increase angiotensinogen, the renin substrate, and increase fluid retention, both of which can contribute to hypertension. This is a dose-related effect and is not seen in the low-dose oral contraceptive. Liver disease was a concern in the past when we were using higher dose oral contraceptives. There was an increase in cholestatic jaundice, and so acute or chronic cholestatic liver disease is a contraindication. Breast cancer is always a concern when women are taking exogenous hormones. The studies showing an association of oral contraceptive use and breast cancer are conflicting. There are studies that show an increase in breast cancer in women under 40. However, the relative rates of these breast cancers is very small, and it is difficult to draw conclusions. Women who take oral contraceptives and then discontinue do not have any higher risk of breast cancer later in life. Other hormonal methods of contraception include the patch and the vaginal ring. These have similar profiles to oral contraceptives with their risk and benefit patterns. Injectable contraception is primarily in the United States Depo-Provera or medroxyprogesterone acetate. This can be given every 3 months and therefore is very convenient. Its mechanism of action is similar to that of the progestogen part of oral contraception. It suppresses LH and ovulation. It also thickens cervical mucus and has an additional effect of altering the endometrium, producing an atrophy-like pattern. The benefits of Depo-Provera is that it can be used in women who should avoid estrogen. It can be given every 3 months, so the woman doesn't have to think about taking a pill daily. It also reduces rates of ectopic pregnancy and ovarian cysts. Another hormonal method of contraception is the implant. In the past, we had Norplant, which had 6 rods, and Implanon, which has 1 rod but was not radio opaque, and currently Nexplanon is the implantable device used in the United States. It has a similar mechanism of action and benefits to Depo-Provera. Risk of Depo-Provera are changes in lipids, including an increase in total cholesterol and LDL, with a decrease in HDL. This occurs when the depot is first administered. The long-term effect of this is uncertain. An additional risk is a decrease in bone density. This is rapidly reversible when discontinuing the Depo-Provera. The long-term effect of this is uncertain. One of the benefits of Nexplanon is that it does not have an effect on lipids or bone. There are two available IUDs in the U.S. IUD stands for intrauterine device. One is a copper-containing device, and the other contains a progestogen or progestin. Both of these have a local effect within the uterine cavity. And do not have any effect on ovulation. These act by producing a spermicidal environment within the uterine cavity. The copper IUD also increases inflammatory activity within the uterus, which inhibits endometrial enzymes. The progestogen IUD creates atrophy within the endometrium and impedes follicular development. Benefits include the long life of the IUDs. The copper device can stay in for 10 years. The progestin device can stay in for 5 years. Risks of these are perforation when being inserted. There's a 40 to 50% spontaneous abortion rate if a woman does get pregnant with the IUD in. But as we've seen, that is a very low risk, as the IUDs work quite well for contraception. There is also a 2 to 4 times greater risk of preterm delivery if the pregnancy continues with an IUD in place. An additional benefit of the IUDs is decreases in ectopic pregnancy rates. The barrier methods work just as the word states. They block sperm and egg from uniting. These include the diaphragm, the sponge, and the condom. In addition, you also have spermicides, which disrupt the cell membrane of sperm, resulting in death or inactivation. The sponge is also contains a spermicide. They do have the benefit of decreasing sexually transmitted disease transmission. The only significant risk is allergic reaction to either the materials or the spermicide itself. Natural family planning uses a menstrual calendar to time ovulation, a basal body temperature chart to also time ovulation. A woman can monitor the production of cervical mucus, which is greatly increased at the time of ovulation, or a combination of these methods. There are obviously no medical benefits to doing this, and there are no medical risks. Postcoital or emergency contraception is used after intercourse, after unprotected intercourse. One would be concerned about an unwanted pregnancy. It involves using a combination of hormones, either a combined oral contraceptive or a significant dose of a progestin. This prevents ovulation and fertilization by the same methods as we described in the oral contraceptive. There again, because of the short duration of use, it is given for 2 doses 12 hours apart after unprotected intercourse. There are no significant benefits or risks involved. So we have talked about hormonal means of contraception, intrauterine devices, barrier contraception and natural family planning, and the postcoital emergency contraception. This talk has included the effectiveness, the mechanism of action, the benefits and risks of these methods. Thank you.